form of a pit. As you can see on the image, it's a pit which is gone in. The second common type of central depression is a collapsing roof. Look at the image. Here, the whole rim is intact and the central roof is depressed. And this is one of the easiest to elevate, and the methodology of elevation also is very typical. The third in the central depression is sinking boat appearance. It has a subtle difference with the falling roof appearance. What has happened here is, here the whole part is completely detached from the metaphysis, and this part goes higher up in the joint. This has lost its trabecular connection with the tibia here. And the fourth type is a free floating, either a line or a topsy turvy fragment. So these are the four major types of central depressions we notice in our tibial plateau fractures. The second major category is a depressed fragment with splaying of metaphysis. So note here what has happened. The tibial condyle has depressed into the tibial condyle, and there is a wide tibial intercondylar distance widening. So there is a splaying of metaphysis. Third is a locked displaced lateral condyle with the fragment depression. What has happened here is this fragment, the lateral, has gone up and locked here. If you just give traction, this fragment doesn't reduce. What we have to do is to put a dura elevator here or a spike, bring it below the femoral condyle and get back into position, and then do the rest of the job. The fourth major type is a depressed whole condylar fragment. Here, the whole condyle gets depressed, and it is easy to elevate because you don't have to insert punch here. This can be done by the condylar clamps, and you need two condylar clamps for this type. And the last one is the complex depression, where the mechanism of injury is really complex, and you need all these skills to get back function for this knee. Friends, we have noted various types of depressions in tibial plateau. There are certain important facts for elevation of these articular fragments. Look at the finer details. I would like to share certain images. Look at this tibia posterior aspect very carefully, and you will find the medial part is more hibernated, more proud. And how does it matter? Because here, if you put a posterior plate for buttressing, this part is well buttressed, but here there will be no pressure. So many times for posterior W type of posterior column fractures, I'll be coming to that in details. You need two plates, one on the lateral side and one on the medial side. If the V inverted V pattern fracture is there, then you can manage with a simple buttress plate. See the image on lateral image on the C-arm. If you notice here, we can note this point very finely. So this is the, as you can see, this is the lateral condyle. So if you see a C-arm image, and I would like focus of everyone, there is an inner line which is the lateral condyle, and there is a outer line which is the medial condyle. And on this lateral image also, I can determine where my punch is going on the medial or lateral side, and gives me accurate insight. Also, at times I would advise you to do this trick in the OT. We put a small dura elevator in the intercondylar eminence so that our eyes are fixed. What part we are looking at in a lateral image. So this is on the intercondylar eminence area. This is the medial condyle, which is a concave part, and the convex part is on the lateral side. So even on a lateral image, we can see through. Even if we don't have a CT in theatre, we can see through which part we are looking and what is the depressed area. Tillman and Moore has given us a tibial plateau view, and they have beautifully described this image. This is a 90-degree X-ray, and this is the 105-degree X-ray. How is it helpful? Look at depression measurement in AP in the tibial plateau view and the 90-degree view. Now, this is the image which is vertical tibial plateau view, and this is the image which is 105 degree, that is the tibial plateau view. So here you will find the medial condyle as a sharp margin, and here you will find it to be hazy. Now look at this depression which he measured. This was measured 12 millimeter on this view, but on a tibial plateau it appeared only 6 millimeter. So it has a relevance when we see the images during elevation fluoroscopically inside the theatre on C-arm. It gives you a view. So we obtain both of these views to exactly elevate our tibial plateau. Study of depressed fragment is important for realignment, and friends, scanning helps tremendously. Like in this patient, if there is a depression like this, if you make an anterior window, this would not be adequate for elevating the punch. Whereas here you require a punch from this angle. So we'll be making a window more posteriorly based on this. Also, if this fragment needs to be elevated, whether this side window is more correct. So I would like to make windows more often on the medial aspect to elevate that depressed fragment. Friends, key to management of depressed fragment, the most important thing is your proper assessment. Taking a traction X-ray. So I would like to take a traction X-ray on C-arm before the patient is dead. It gives a lot of idea. Applying the distractor force, elevating the depression, and then fix and buttress. Maybe with graft or without graft. Looking at the X-ray, look at this X-ray. The decision, my decision was possibly pressing. But after this, I was surprised. CT gave us exact injury, and that required buttress plate. Also, it gives me an insight that this buttress plate have to be a very low profile buttress plate because they are very small fragment. And then this patient was operated with this buttress plate giving exact articular alignment. For all this elevation purpose, we need variety of elevators or punches or temps. We may have a direct punch, an angle punch, or a step punch. At times we need a KY assistance to hold that fragment into position, or at times a bone graft punch. I will be coming to one by one all of these elevation. What I would like to emphasize, when we purchase our punches, they need different radii of curvature. And at times a straight one is better, at times with a wide surface is better, or at times a punch with a small tip is better. So we need all these punches, and usually on your tibial condyle trolley, we keep around 6 to 8 punches ready. And the aim of this punch is to keep all the fragments elevated till we hold them until we fix them. And these punches are really helpful for tibial depression practice. CT definitely gives us the idea and imagination for appropriate punch for this elevation purpose. Now look at this image. Here, a window would be made here, and you need a punch which is significantly larger size, and then only you could get that these two position. In this image, imagine the punch for this. For here, you need what I call as a shoehorn punch or a sort of a Intra end punch, which gives the tilted view of the punch, and then you can elevate that fragment very nicely. You need to elevate and compress only. Here there will be no need for graft. Now this I like to call as a roof collapse. And you can see the CT image as if the whole roof has collapsed. The side wall is there. So what you need to do is to get this roof back to position and then compress. Once you compress, there is no void, and then there is no need for graft in this case. This is a case which requires our imagination. Here, if you directly punch, the fragment would lose its three-dimensional position and would be lost in the open space there. So you need to compress this area first and then elevate with the window. Elevating with punch and disc of bone at times is required. So if there is a central depression, fine punctate fragment, then having this disc of bone, which you can take out from the same window, and then elevating with this punch nicely reduces this wall back to its position. A medial window for inserting punch I usually like, and I would like to share my experience for making a window medially with a small shape which is not rectangular, so that there is no sharp edge, so that we avoid a stress riser effect. We have to plan our window exactly, and I would like to have attention here that this is the tibial window which we make on this side, from which the punch can be angled out. And here on the lateral tibial plateau, the posterior part is bit inside. So at times the punch can't enter the more posterior part, and therefore you need more radii of curvature. When we punch, it also takes away the bone graft effect. So it provides a subchondral support to that elevated fragment. Friends, most of the times punch is inserted from the medial side, but at times a lateral side punch is useful. As you can see in this image, if you see this fracture fragment, this cannot be elevated from the medial side. It would get pushed. Here it can be elevated nicely from the lateral side. Also look at this image. Here the lateral plateau is depressed, but if you want to elevate from medial side, it is not possible. So you have to judge from where side, which side you make a window, either medial or lateral. CT exactly helps in exactly locating the direction of the 10 fragments which have been described, which area we want to elevate and which area we need to buttress. Depression like a roof collapse with condylar spring is the easiest to elevate. So whenever I have a patient where this CM image is there, I'm very happy. I'm sure this does not require meniscal elevating approach, disconnecting approach. It does not require a complex maneuver. What it requires is that collapsed roof has to be brought back into position. And how this is done? Very easy. Get the punch below it, way below it, and then start punching. You can see the animation, and this I call as a cine effect. So if you keep our C-arm stand still there and take multiple shoots at that level, it gives you exact idea that this is elevated. So it is depressed. Now it is fully done. Now note the vertical line drawn from the femoral condyle on medial and lateral side. You will find splaying. So whenever there is a depressed tibial condyle of root type, root collapse type, or sinking boat type, the condylar width is increased. Wow, you have to now reduce the condylar width so that all the void in the cancellous area is reduced. And this can be done very nicely. So once we reduce this, then it can be very well done. The other type is sinking boat. This is different from the collapsing rule in that this area, this part has lost all its articular continuity. And if you start punching, then the portion also rises, giving us a sinking boat. Surface of the boat comes on one side above the surface of the tibial plateau. So what we do, just lock with the KY here in this direction and then start punching. Then it will be elevated properly. This is very also important to check in the lateral view so that we make our elevation force perfect. Now you can see on this image, the punch has to go below this dense condensation of bone, which is the depressed area. If our punch goes in this direction, this part will not be elevated. So we need both the plane imaging. If we compress effectively, the void reduces. And this picture shows that the condylar width is reduced and after this elevation of the punch. Collinear clamps are very effective in compression. However, many times I have found difficulty with collinear clamp. What we need is a clamp that can hold onto side wall very effectively. I will show you the clamps in the next slides. These are the patterns and modes of elevation various constructs. So here, compressing the condyles at 2 points immediately after elevation. Here there is a double clamp. So if both the walls are shuttered, you need double clamp to hold them, reduce the weight, and then elevate the clamp. This is the metaphyseal, epiphyseal compression, and then elevation. Friends, many times I find patients coming with simple screws buttress on a lateral wall fracture and the lateral depression. However, if you analyze them, the wall is totally collapsed. So there is no point in putting cancellous screw alone. What it needs is a good elevation and buttressing. So this analysis is also important. The major central depression, at times, if there are multiple small pointed fragments, then you can elevate with a bone graft below that. We'll see in the image. So this is what I am doing with the graft, and the graft takes up small punctured depressed fragments along with it. In the lateral film, we have to fine-tune elevation of all these fragments. Now, as you can see in the images, so this was a fragment which is depressed. Then punch goes beneath that, we lock the surrounding areas with the another K-wire, and then get that exactly. So this has come very nicely. Now this needs a raft. So unless we do a rafting here, that fragment will depress again. So we pass a K-wire initially, and that can be converted into a screw later on. So this was nicely elevated. With depression modality of elevation, I found the biggest difficulty. It is difficult because multiple fragments have sunken low deep into the condyle, and all fragments may not align properly. And this is one category which requires a meniscus lifting or a sub-meniscal approach to properly align the fragments. Look at the operating setup for a plate depression with a split, where clamps are applied in a buttress with a plate from one side, then elevate with a disc at bone to get back the articular congruity. This is double clamps applied and either a Higa's dilator or a smooth punch to the small window from the fracture plane. Here you can see the fracture widely displaced, clamp is holding the reduction. So in complex fracture, our armamentarium becomes complex and we have to execute the manner. Here the elevation is done through the oval window of the plate, plate is applied on low profile plate and we just need to elevate this fragment. And this can be very nicely done with a flat punch going through the oval window of the plate. This type fracture bends requires intra-articular approach to reduce the fracture. You can see I gave a lot of traction and this never reduced. So we have to put a dura elevator here and a spike so that we reduce it and then the whole surgery can be undertaken. Intra-articular fragment, which is topsy turvy, requires nothing else but open reduction and internal fixation. Wherever that fragment is, from whatever approach it is suitable, you have to open the joint, get that topsy turvy fragment rotated back, and then fix appropriate, as was done in this case. Meniscus lifting approach for lateral condyle complex depression is required approximately in 10% of cases. Now look at this fracture. Here we just can't analyze which fragment is going where. And here if you just elevate with your pen or the elevators, that is not appropriate and the feel good never comes. Here we need a meniscus lifting approach. And I would like to give one or two tips here how to get this space there. One is a distraction force, either by a distractor or I like to use this distractor plan. So this is used. So we can focus on the distractor.
Yeah.
So this is called the distractor plan. So this is very helpful. You can take 2.5 and 2 mm ferrite and then that clamp you can distract. So we get enough space, almost quarter to a centimeter, and then a dura elevator goes beneath the meniscus. So we can see all the depressed fragment. At times we see a bony cancellous surface on the top and the articular surface depressed. So this topsy turvy fragments also we can rotate there, we get enough space. Here we have to take certain bites and sutures on the meniscus. So click them at 2 points, one anteriorly, one in the middle, and one posteriorly. Flip the meniscus on the other side, and then you can execute reduction very well. See this fracture. Here, if you reduce with a clamp and only stems and the elevators, that would not be anything because here the fragment anatomy, the fragment rotation is not very well understood on a Siam guided image. And this patient required meniscus lifting approach and buttressing with the plates. This is how the image is intraoperatively. And once you start fixing those multiple fragments, get them bent at position with multiple directional K wires, understanding the location of plate. And these are the suture wires in the meniscus placed appropriately. So we need minimum 3 to 4 sutures, and then they can be locked either onto the screws or on a super anchor or onto the plate hole, whatever is appropriate in a given situation. Lot of this buttress plate and the graft plates have holes to take these sutures. Friends, we have understood certain types of depression and varieties of fractures. Understanding depression and appropriate elevation is emphasized in depressed tibial plateau. So a series of this image. So look at this image. At the cursory glance, it looks innocuous, but you can find that there is something wrong here. Also, whenever you find splaying, splaying means there is a depression. There is a weight enlargement. So unless there is depression, splaying would not happen. So look at the image on the lateral plane, and here the temp has started elevating. So you can see the temp, and this CA radiography gives a beautiful insight whether we are completely elevated or yet to elevate completely. So obtain this image, and all of these lamps have this facility. So this was then elevated, reduction with the wire. Now you can see the whole fragment is elevated, and you can see the fracture plate separating from that part. And fixed with wrap plate, giving adequate function after reduction in the condylar weight. This wrap plate provides fixation for the structure. Friends, after we have elevated the depressed fragment, the next task is holding the reduction till we provide appropriate fixation. How do we do that? The punch is one which keeps it elevated. Once the reduction is achieved of the plateau, then we hold the clavus at the subcondylar level, and the condylar width, we find that it is increased. So now we have to reduce the condylar width by appropriate clamps. So you can see after the punch is elevated, then clavus is pushed on the other side, and now it is holding in multi-direction. The width is now compressed. So this is the plate clamp which I was mentioning. So the plate clamp, when we apply a clamp, I would like to have a focus on this image. On the lateral side, lateral condyle, there is a cancellous bone. So whenever I put a routine clamp, it buries inside. It goes inside and does not give adequate compression. So this plate clamp, which provides adequate compression on the cancellous bone. The medial side, as you would all realize, is a tough bone. Here the clamp doesn't bury it. So we can use this clamp specifically. Many times we need bi-plane clamp. This is another clamp which I like to use quite often, and this is a sort of a ohm clamp. It has a shape of a ohm which takes up the anterior-posterior width very nicely and compresses on the posterior displacement. This clamp helps in aligning the fragments better. Polyene clamp also does well, but I like the other clamps more often. This is the clamp design, which this is a ohm clamp and a plate clamp. They are very useful in condyle fractures. This clamp avoids burying of the clamp in cancellous bone on the lateral side. After we have done elevation, we have held the reduction, is now fixation. And now we have to provide an effective fixation. The consensus for fixation in tibial condylar fracture, for split fracture is ORIF with buttress plate or spool. Depression fracture, we provide subcondylar rafting, and for bicondylar fractures, we provide both medial and lateral support to prevent varus or valgus deformity. And analyzing which column needs buttressing, either the medial, lateral, or posterior, depending on the circumference, we decide what buttress is needed. So when we begin a fixation, we always obtain this image and condyle. Now in this image, whenever we start a case, we take this image and then we discuss it later. What are the skills we need in managing this fracture? Now if I enumerate, we need length maintenance, we need axial alignment, we need condylar plateau depression correction, we need varus management, and we need bicondylar constructs. And also we will have to execute these through Miko approaches so that movement is broken. So we see all these things and then decide to appropriately. There are plethora of plates available nowadays. How do we select? There are lock construct as well as non-lock construct. Over this last many years, we use non-lock constructs, and in certain situations now, lock construct definitely provide a suitable answer. The wrap plates are wonderfully molded anatomically. As you can see, we don't have to mold them; they are anatomically molded. And it is very nice for lateral tibial plateau differential fractures. We just have to know the contour differences. There are certain plates which are more straighter. There are certain plates which are more offset. These are the simplest plates which have more or less offset plates available. And depending on the situation and the type of fracture, we have to utilize these plates. This corner, if you are using a non-lock plate construct, you will have noticed in previous patient, many times when the patient bends the knee, he tells us, this is hurting me, this is popping out. So this corner is what needs a small buttressing, and this can be very well done by just bending the ear part of that plate. Also, we need to understand curvatures of various plates. This plate you can find is more curved, this is more straighter, and in our tibial condyle armamentarium of implants, this all should be available because there are various types of fractures and various types of fracture patterns and the bone patterns we encounter in India. Friends, we have various plating options. Lateral plate wrapped, adding medial support, double plating, lock plating, and we have to choose whatever is going to give the best hold onto the fracture. And this is important to analyze by incorporating in our practice which column needs buttressing, where is the apex of the fracture, and on that depends what fixation we are going to provide. So whether anterolateral, anteromedial, posterolateral, posteromedial. So this diagram definitely gives us a lot of insight, and see exactly we can plan out the fixation. Friends, simplifying isolated lateral column fractures which are only split condyle, only buttress plate would suffice. What you need to do is just provide a buttress and a subchondral wrap, which can be done by non-lock construct as well. Especially in a resource poor situation, many times in India, we'll be using that. Lateral condyle with articular depression, like in this case, needs elevation of the depression and then providing a wrap. I would like you to have long 3.5 millimeter screws as wrap screws, especially for those category of patients who cannot afford costlier wrap plate. Wrap screws always support subchondral bone very well. As you can see here, this fracture otherwise in a buttress plate would not be held, but with a wrap screw that holds very nicely. And this rafting principle is very well supported by the engineering raft principle, the tubular metal construct with no grafts even, and the anatomic reduction of the osteochondral fragment is very well held by the raft screw. Only thing we have to do is to place this rafting screw below the depressed fragment. Unless they are below the fragment, it is not going to raft it well. Friends, also I would like to emphasize, many times we have to put this raft plate exactly where it should sit. So we have to do a bit more, go posteriorly and put the raft plate more. So a thumb presses it, and then I would like to lock that with a small K wire so that that plate remains. Otherwise, it offsets anteriorly. So we have to minimize our plate placement errors, and this is how exactly the raft plate fits. Many times this part remains anteriorly, and here also we have to see that it sits very well. How I begin a case? It's simple. Most of the times the knee has a lot of hematoma, so I take a 14 gauge or a 16 gauge needle connected to the suction tool, and as soon as that is inserted, a lot of blood flows out. How does it help? It reduces the blood losing out through the incision, and the field is not messier. Then we plan our mental incisions. Usually in a bicondylar fracture, I call it as 5 incision techniques. The limb is red, and I like to always use 2 blocks of knee. We call them as knee blocks, so that we can exactly position the knee during surgery. Also, C-arm imaging becomes easier. So here you can see if the fracture is such that you need extension, you can keep both the blocks on this side. If the fracture is such it requires for reduction, flexion, we would put the knee blocks in this fashion. And look at this. In this case, the surgeon could not anticipate that, and the tibial plateau was reversed. So with a simple position of block, this could have been managed more effectively. Now, after deciding about the incisions, we plan the plate length and 5 incision technique. I call this as 5 incision technique. We take for the medial method, the distal end, the proximal lateral end, the proximal distal end, and elevation for a window whenever required. This is the setup to develop the sub-cutaneous tunnel by a scissor and a long periosteum elevator so that we get a good tissue healing. The C-arm image helps plan elevation window properly, and this is my rough mental planning where my window would be, how would be the punch going, so that it gives exact location where we make the window. Here we have elevated the base fragment, and now we are compressing with the clamps so that we get the width reduction. And then is the raft plate on the lateral side. Here I like to emphasize that I do not like to make incision on the shin. I like to take incision 1 inch away from the shin so that we will get the exact lateral trajectory for drilling as will be seen in one of the images. So the friend, for this complex structure, the mantra is reduce, hold the reduction, compress, and then fix. That is our usual sequence. Fix the raft plate on the lateral side, and then if required a medial buttress on the medial surface. So elevate, reduce, hold, compress, and then fix. This is the diagram I like. sequence of application of screws in plating, if there is not a condylar width which is increased or intercondylar distance is increased, then a lot of splaying is there. Then we fix this screw, then on the other side, then put these screws, and this gradually bring the condylar width into position. So principle we can utilize. After fixation, friends, and elevation, then we do test the range of motion and table. We should not have any crepitals, the alignment should be fine, the reduction should be fine, the oblique plane instability is there, we should notice at this point of time. Always look and assess for posterior medial fragment. So in planning for fixation, if there is a posterior medial or a posterior lateral fragment, that should be planned very beginning, and we must provide an effective buttress from the posterior aspect. For a posterior column, look at this image. Here on the AB image, you can find the pattern of posterior column injury. At times, we need both the medial and the lateral plate. This is best managed by posterior medial plate and a lateral lock plate and a complex fracture. Identify whether it is a V or a W pattern. What I mean is a reverse V or this pattern on a CT. So here you require a plate which goes on the medial side mostly. In a W pattern, you need a plate which is wider or a T buttress, or you need two plates. So that image on X-ray itself we can make out what type of construct we are going to do. However, if we have CT, that always helps us better. For a posterior lateral corner depression, we need a very small construct. We don't need a large plate. And at times, whatever small Smith plate are available, we have to cut them. For a complex bicondylar fracture, reducing and folding before the plate insertion is important. So we reduce the width, get the alignment, compress on the side, hold with multiple K-wires out of the range of plate, and then fix. At times, we require various reduction tools and good plates to compress this intercondylar eminence fracture, which can be held to the bicondylar fracture, intercondylar eminence fracture. You can see converging K-wire helps to pin that fragment into position. Otherwise, this fragment, when we compress, ejects out into the joint, leading to flexion deformity, which you will find in certain of our patients in the OPD. At times, friends, use of 3 no profile plates may be needed, as was needed in this case, providing the apical instability occurring at this junction. But they are thin and no profile plate. Posterior and lateral plate is a win-win situation. Use effective buttress from the posterior side, and then you can do the rest of the job on the lateral side, as was done in this complex fracture. Now, specific posterior condylar plates are available, and they fit well to contour of tibial condyle very well. Rim depression, at times we have to use a rim plate, as was seen here, a simple reconstruction plate used as a rim plate, and they were not available, that was used. Friends, in tibial condyle fractures, all of us would encounter certain complications, and I am enumerating certain complications which are there. The most common infection we should avoid: virus, loss of congruity, decreased range, failure to manage instability, failure to manage alignment, failure of proper implant selection, and failure of proper implant placement are not uncommon, as we'll see in certain of these 2 X-rays. This was a patient where in a thin skin patient, almost the skin was just parchment, hardly you were able to pinch out the skin, and the large lock plate construct just gave way. This was a thick profile implant which led to loss of these tissues. Here, we have to use appropriate plates in a given patient's approach. Another problem we quite commonly see is caving in. What I mean is, this caving in or intersusception of fragment here leads to varus deformation. So, I would like to pay attention to manage this caving in by correction, plateau correction. What I mean is, pass 2.5, 3 K-wires in different planes, and then hold it separated out, and then a Dura elevator helps to remove this intersusception and then fix and plate push up. Where there is varus, and loss of flow. This is a double trouble. This patient would never be happy. So we have to see this during our fixation. Unsupported medial column, even when the locked lateral construct is there, cannot prevent errors. So in this severe bicondylar injuries, we need a bicondylar construct. These plates should have been inserted more posteriorly on medial condyle to avoid varus. As you can see, the surgeon just failed to get back dissection posteriorly. Otherwise, this varus should not have happened here. To summarize, friends, our patient desire good pain-free range of movement, and we desire long-term articular cartilage preservation and function. All of us desire this, and our patient want a good function and functional knee. For this, we need to improve our armamentarium, reduce time of surgery. I would advise use of 2 drills. In a routine tibial condyle surgeries, there are minimum 1500 exchanges of instrument. What I call is, when I counted, the tibial condyle surgery is one surgery with the maximum amount of assistances you do. So you need to pivot, then condyles, clamp. So almost 1500 exchanges happen between the assistant and us. And therefore, if you use 2 drills for leg function, we use screwdriver on the drill itself, that helps reduce the time of surgery. And we must produce a construct suitable to hold the union and allow early mobilization. That is our aim. Various combination of plates thoughtfully selected give equal result. We can choose whatever gives the best result in our hand and suits the requirement. In conclusion, I would like to say that analysis of patterns of depression, which we find in tibial plateau fractures, has resulted into better articular complex, saving precious time and resulting into better surgical outcomes for our patient. Friends, elevate plateau, elevate mood, feel good. I would like to thank all the contributors. And now I would like to hand over to Aditya for summarizing the types of depression in tibial plateau fractures. I enumerated the various types and the constructs we which use. So Aditya would just summarize whatever we have spoken till now. Aditya, welcome.
Good evening all, and thank you sir for this wonderful opportunity. So I'll be summarizing the types of depression of tibial plateau fractures. So in the central depression, there can be a pit depression, it can be a collapsing root, there can be a sinking foot appearance, or it can be a free floating fragment. And then there can be a depressed fragment with slaying of the metaphysis. There can be a left distal displaced lateral condyle with fragment depression. You can see on the X-ray. There can be a free floating topsy turvy articular fragment. The fragment turns upside down. There can be a depressed condylar fragment, and there can be a complete depression. I'll be
handing over to Rahul, who would summarize the constructs required for various types. Welcome, Rahul.
Hello everyone. Thanks for giving this opportunity. Here we can see type 2 tibial plateau fracture from structure classification. Here there is a fracture of the lateral condyle of the tibia with depressed fragment. Here we require elevation of the depressed fragment and compression of the condyle, and buttress plate with reft screws or reft plate from the lateral side. In this case, type 3 tibial plateau fracture, here there is a depression in the lateral condyle which will require elevation and fixation with reft screws only. Here we need not do any compression of the condyle. In type 4 tibial plateau fracture, there is a fracture of the medial condyle which will require elevation with the use of clamp, and we can buttress it medially. In this type 5 tibial plateau fracture, here we can see the depression in the lateral condyle and fracture of the medial condyle. This will require elevation of the depressed fragment and compression for getting the tibial condyle width, and fixation with the buttress mode from the medial side and reft screw from the lateral side. And in type 6 fracture, we can see that it's a complex type of injury showing depression, tibial width, and combination, which will require elevation of the depression, compression of the condylar width, and minimally invasive fixation from both the condyles. Thank you, sir.
Thank you, Rahul. Thanks for that summation. And I must thank all of you for your kind attention on this Sunday evening. Tibial plateau fracture is really day-to-day surgery for all of us, and with the increasing speed of vehicles, we find them more and more complex type of tibial condyle fractures. Ashok, I would hand over to you.
Thank you very much, sir. That was a really comprehensive presentation on all kinds of plateau fractures. So it's time for questions now. So I have few of my questions, and then we'll take the questions from the forum. So you talked about the implant, the non-locking plate as well as the locking ones. So what are your indications for use of locking plates?
All those patients who have a lateral plateau depression with lot of osteoporosis, multifragmentary depression, multifragmentary fragments, these patients are best managed by lateral RAF plate. And now beautiful plates are available. I go back to my area of registrarship in UPs where these constructs are not available. And what we used to find that we used to put plates, buttress them, but then we used to find depression at a later date. With the availability of this RAF plate, that now is quite minimized. So I would advise RAF plate or locked RAF plate for lateral condyle plateau depressions. They are the best to manage them, along with the RAF principle of screws, additionally, or along with the same plate.
Right, sir. The other question was your approach to this fracture, the incisions, and what approach do you take for different kinds of fractures?
Yeah. So at the outset, we have to have a good analysis. We get all the inputs before we have the soft tissue, good control. We have waited enough, and then we analyze with the CT scan which column is injured. If it is pure medial column, the medial approach, lipo fashion. If it is pure lateral column, pure lateral approach, lipo fashion. The lateral lipo is mostly sub-periosteal submuscular. And if it is pure posterior column, it is posterior approach. If it is posterior lateral column, then we go ahead with the posterior lateral approach. Many times you find a combination of approach required. And most commonly, we have to combine a posterior medial approach, which is a reverse L approach, and a lateral approach for the complex fractures. So we have to use various approaches, and not one would be enough. We have to use whatever is required as per the column injury.
So when you are using this dual approach, does the position of the patient change? Are you position him on the... Yeah.
That's very nice, and that is always a question in mind. Do we take the patient into supine position, have a figure 4 position, and then a lateral approach, or we make the patient prone, fix the posterior condyle first, flip the patient again on the table? I find many times we are able to manage with figure 4 position, but then the complexity is to get that reduction. So somebody has to hold the limb into wide abduction, keep it elevated, extended, because these fractures reduce in extension, and then we have to lock with two wires and then hold with a plate. But I am more comfortable using a posterior approach prone position, fix up posterior jaw first, and then flip the patient. The only thing we require is a separate set of linen and changing over the position. The advantage there is you remove the tourniquet, hold that part, and then come back on the lateral side. So in certain patient, I would use a figure 4 position, and in certain patient, I would use a posterior prone position, depending on the complexity of fracture. Especially in the W type of fracture pattern, which we identify on the X-ray, I would like a posterior prone position.
Right, right. So there are some questions from the forum. Dr. Nitin is asking, do you do CT scan for all fractures?
Most of the fractures I'm comfortable doing CT scan, but as I mentioned, in resource poor situation in India, our 2 time taken X-rays, 2 plane X-rays along with C-arm elevation. So now I identify certain types. If there is a roof collapse type of depression, if there is a sinking boat appearance, these are large fragments which can be very well seen on C-arm. I may not order a CT scan. If patient is affording, if it is easy and resources are available, I would always like to go ahead with the CT scan. More lesser the injury or more indication for the CT scan. That is the best way to plan these fractures. But many patients may not be able to afford that, and I would be carrying out these surgeries even without a CT scan, with good X-rays and good CT scan and C-arm availability.
Okay. So Dr. Praful is asking, many times the depressed fragment cannot be seen on C-arm, but can be seen on X-rays. Have you encountered this?
Yeah, this happens if the resolution of C-arm is not good enough. The ways to do that would be, ideally, we must get a C-arm, the image intensifier, close to the patient's bone, one, remove all the metal artifacts. So what happens if there are certain punches or metal or periosteum elevator in the field, the C-arm, the automatic dose regulator, the ADR in the C-arm may not pick up the right type of factors. So that may obstruct the image. However, if this is happening, obtain C-arm image in two planes, you will find somewhere more condensation of trajectory. You will find a dense bone there that can pick up. But yes, this can happen. And if this is the situation on table, you are confronted with such a situation, the best way would be to do a meniscus lifting approach so that by our vision, you can find out the
Right.
situation.
So Dr. Pushkar is asking, how do you manage patient position for posteromedial and posterolateral fixation when required?
Yeah. So with many of the times, the posteromedial and posterolateral fragment, if that is one continuum of fracture, like if you see on a ATFL or W pattern, and if they have some connection, then it can be managed by the posteromedial approach. You just have to do a L reverse, take the incision horizontally across the knee, and then elevate it, going to the other side of the condyle. That is possible occasionally. But if both the fragments are separate, then we need to have a posteromedial incision and then a short posterolateral limb of the incision on the other side. That is a complex scenario, very rarely required.
Right.
Most of the times I am able to manage by the median. And then if you push the subperiosteal finger, go to the other side, put your finger, tap that fragment well into position. Unless there is a depress and the condyle has rotated, if you are able to put it, then you will be able to manage with a plate which is wider, T-type, or two different plates. And these plates are many plates on the lateral side.
Right. Dr. Nitin is asking, do you do fibular osteotomy for approaching posterolateral fragment anytime?
I have never done a fibular osteotomy because that need I have never felt. The availability of Frosch approach has given a wonderful approach where we make a lateral orthotomy and then we go posteriorly. And here, what we need to do with that condylar part, actually, if you see the posterior condyle and if it is turned, that is what we need to get back into position and look at the femoral articular surface from the window on the lateral side, and that has not required. That doesn't require osteotomy approach. I have never done myself a fibular osteotomy for any of these factors.
Okay. I think we have a surprise here. Dr. Gadegone has joined us. And,
most welcome, Darwin, sir.
And
Chandak sir.
Yes, sir. Most welcome. Go ahead.
You have done a wonderful job today. But I want to ask two questions to you.
Yes, most welcome.
How do you manage if the concomitant ligamentous injuries are there? You manage at the same time if you are suspecting, or you manage after a fracture is healing? One question. And in my observation for the years of practice and others also, in proximal tibial fracture where there is a global involvement, there is a large soft tissue factor is also in that particular fracture. And if you give a 1 or 2 or 3 incisions, probably the chances of skin breakdown and infections are much more. Now, in your practice, and you are expert in this thing, what is the take on this bone breakdown and the ligament?
Very rightly said. Answering your first question first, and that was, how do you manage the ligaments of injury happening along with tibial condylar fracture? Now, most of the time, the ACL avulsions or PCL avulsions can be tackled at the same sitting. Now, these are very easy to fix. You have a bony chunk, so intercondylar ACL avulsion, I would like to manage at the same sitting, either a open or a pull-through suture through that condyle and fixing them with the whole of plate. A PCL fracture, I usually first finish up the first surgery of tibial plateau and condyle. Then after 3 days, I would like to do a posterior PCL avulsion. So I would like to combine these fixations also. However, if there are avulsions on the medial tibial plateau and the lateral tibial plateau or the collateral ligaments, they are difficult to manage if you are able to get them with the pull sutures, but that is a rare occurrence. Most of the times you find either PCL avulsion or PCL avulsion, and that I would like to manage in the same sitting. Because if you like to manage them later on, those fragments cannot be brought back accurately to the position. So avulsions of ACL and PCL, I like to manage in the same sitting. Coming to your question of soft tissue, and that, as we have all learned our days from routines, that initially when we used to give large incision, the healing was really precarious. With the advent of NIPO, what NIPO has given, NIPO has brought back to that idea where we incise or plate insertion, rest of the tunnel is made subcutaneous or subperiosteal on lateral side, and we respect soft tissue so much. Nowadays, out of my last around 200 cases, I do not recollect a patient where either the implants were immediately required to be removed, or we had a very poor soft tissue healing requiring soft tissue reconstruction. But in previous era, soft tissue reconstructions were very common. We have to go with the gastrocnemius class. However, if infection happens, that has to be managed separately. Yes, healing in tibial condylar fracture is precarious many times, and therefore judgment for when to embark on surgery is very important. Unless the whole soft tissue edema has come back, unless the wrinkle sign has appeared, unless the soft tissues are healthy, you really should embark on a tibial condylar open surgery.
Thank you, sir.
My third question.
Yes,
sir. My third question, though there are the classifications like SATSAs and so many other classifications, but most of the time there is a global articular injury, and it's very difficult by 2 incision and even 3 incision also to reconstruct the articular surface. In that case, after a temporary articular surface elevation, do we advise external spanning external fixator for some time, and then we do a definitive fixation?
yes, and I would really note this point very well, that there are certain occasions where the tissues are not optimum, where compound fractures, where the tissue healing would not be very good, and in these cases, I like to put them with a hybrid fixator. So what we do, the top level we put a ring, get all the articular fragments aligned, put subchondral wrap or wires, and then put a hybrid fixator. Yes, it is a very useful tool in managing this complex variety of fractures. However, that may be required in less than 1% of patients, and the results are excellent. So what you can do is, immediate weight bearing can be started as patient can tolerate it, and it avoids large dissection of fragments and does not denude the fragment. So I would appreciate your point that yes, there is a room for managing these complex fractures with the hybrid fixator or an external fixator, yes, appropriately when needed.
Thank you, sir.
Thank you very much. Thank you, Ashok Sam.
Thank you, sir. There are a few more questions for the forum. One is about the soft tissue. So Dr. Rahul is asking, should we commonly do MRI for these cases? And what is the indication for MRI?
So my indication for MRI is, whenever there is lot of instability noticed on clinical examination, one, soft tissue swelling inappropriate to the fracture displacement, very minimum injuries noticed on X-rays, but gross swelling. In all these patients, I would embark on both CT as well as MRI. So CT gives me more insight into the fracture fragment geometry and where they are located. However, MRI as a routine tool, I have not yet started doing in every patient. If available, yes, that would be useful. But I think even doing MRI, we are not able to appreciate everything into that totally shattered area. So I would do MRI targeted for those patients where I need to plan to know whether the PCL avulsion is with a very tiny fragment or it is plain PCL injury or the wake-up bone is there. Those informations I get with MRI. Yes, there is a room for MRI. Possibly, if I recollect, out of 50 patients, I would be doing MRI in 1 or 2 patients, not all.
Okay. The other question from Dr. Rahul is, does the window from the opposite side need stabilization?
Yeah, so now whenever this elevation is done, this window is an oval window. As you can note, the window is made onto the medial surface, and the window is made exactly at a point here, and that is an oval surface. So once you create an oval window in between the posterior edge and the anterior shin, then this does not require buttressing on the other side. If the column is broken, then you need buttressing on both the sides. So if medial column is broken, lateral column is broken, then you need buttressing on both the sides, and the window is below the plate.
Right. Dr. Pushkar is asking, how often have you resorted to meniscectomy during plateau surgery?
Yeah, not during the surgery. So certain of these patients where we found that the plateau was not elevating with the punches and it was just not getting reduced. So we resorted to meniscal lifting approach or a sub-meniscal approach and found that meniscus was stuck up. So here I always keep in theater the meniscal repair set ready. So if the meniscus is torn in between, then we can repair it, because then here the plateau is quite depressed, and with the distractor we can repair that meniscus. And then from the periphery I take 4 or 5 sutures and then give it to my arthroscopy colleague 3 or 4 months or 5 months down the line if there is gross stiffness to reduce the intra-articular adhesion, and then do a meniscus job. I have not yet excised a meniscus. Few patients I found the root was avulsed, and I was able to manage that root avulsion also with the tunnel, getting the suture and tying that root to the position.
Right, right. So you showed us the clamps. So tell us some tricks and tips about how to apply them, and also where we can get those clamps.
Yeah. So I will take help of my colleagues to hold the bone.
Right.
So this is the bone. So what happens on the lateral side? The part of the bone is cancellous. As you can see, the lateral plateau bone is cancellous. The clamp buries in. The routine clamp, which has a ball stopper, even that ball stopper buries in, and it doesn't hold. So when we compress it, this buries inside. So this clamp gives a plate is there onto this clamp. As you can see, the plate swivels around. So you can swivel all around, and it is held in position. And then we apply to the clamp to it. This has a facility of putting either vertically or horizontally as is appropriate, and then this you can drill KYs into it so that the fragment is held into position. You can flip it up or down. These clamps are available from Scan Surgical, who has given the know-how for, and he has made the clamp for us. And I find these clamps really very useful.
Right. Okay. Through this classification, can you decide pre-operatively that this case will need a sub-meniscal approach in some way?
And thanks for Ashok for that question, because that is the advantage of doing this analysis of depression of various tibial plateau fractures. So when there is a roof collapse type appearance, here what has happened, the rim of the condyle is intact and the central roof is collapsed as one unit. So this can be elevated punch, and it comes exactly into position, not with KYS and then put the construct. And on CM also you see an exact elevation. Immediately the mood of whole theatre becomes happy. They said, "Sir, aa gaya pura." And then they would ask, "Ek punch aur de do." And then the whole reduction is done. This is easier. So I can predict that this fracture is going to come with the CM assisted one day. When there is a sinking board type, then they would ask me, "Sorry, K-wire hold karo." And then after holding with the K-wire and then elevating with the punch, that comes very nice. The difficulty is in the pit depression, and then fragments with multi-layered depression, and then fragments with multiple punctate fragments. So these are the fragments which, even if brought up to position, you are never sure that you have aligned the articular surface congruously. Also, some of these fragments may be tilted, and then a sub-meniscal approach is there. So in a pit depression, my threshold for going for meniscal approach, sub-meniscal approach is quite low. I would use it more often. So this classification gives me an idea. Yes, you may be prepared for more of this exploratory approaches.
Right. Dr. Venkatesh has a question. What is your post-op protocol for these patients?
So all of these patients, whenever we operate, at the end of the surgery, we palpate for the compartment, and if in the lateral plateau depression we find compartment somewhat tight or just not tense or not good enough to feel, I would go ahead with the fasciotomy in the same sitting through the two windows. We connect the fascia incision so that a fasciotomy is carried out, and then we elevate them on a routine roller spin with a true elevator at it. What I mean is, on a roller spin, many times the condyle is like this. I would like to elevate them. Next day, I make them sit at the edge of the bed. All the tibial condyle fracture essentially should sit on the edge of the bed, what we call as SOED, sitting on edge of bed. It automatically gives them 90-degree flexion, unless there is a tibial intercondylar eminence fracture. In those patients, we have to give them a brace, let them heal the condylar eminence. But moving them as early as possible on a CPM machine, allowing active toe movements, and the next day they start on a walker with a toe touch, not giving any pressure. We give them a weighing scale, and on that day we teach them not more than 5 kgs initially up to 6 weeks. From 6 weeks to 3 months, give them around 15 to 20 kg weight transmission, and the weight bearing actually starts at around 3 months.
Right. Dr. Gadegone has another question. How often do you encounter lateral peroneal injury? And if it is there, how do you deal with it?
Yeah, that's a very difficult question, and especially if there is a lateral popliteal injury, pre-operatively that is very easy.
Yes.
Anytime you get a foot drop post-operatively, that day you can't take your dinner also. You feel really bad that the patient has suffered this.
Right.
It can happen if there is a fibular fracture, if there is a fibular head fracture along with the tibial condyle fracture, because the nerve can get entrapped here. Yes, I have faced certain pudendal punctures, but most of the times they recover. I have yet not damaged a peroneal nerve by any of the approaches, and most of these patients recover over a period of 1.5 to 3 months. But it happens, we have to be aware of it. It can happen, especially when the lateral part is quite comminuted or there is a fragment which is poking the nerve. If you find that there is a fragment which is poking the nerve, I would go for a more exploratory part of approach rather than an approach.
Right. Dr. Nitin is asking, do you do arthroscopic assisted reductions anytime?
I just carried out only one orthoscopic assisted approach, and after that I decided this is no better. So the orthoscopic surgeon who was assisting me was again and again asking for the Siam shoot to see whether that reduction is effective or not. I was never comfortable, though I have seen the reports for split and punctate depressions, it can be done. The biggest danger, as happened to one of the colleagues who had a compartment syndrome of this after this orthoscopically assisted, I have never myself done it, would not recommend it myself, but there would be occasions. What it can lead to is if there is a meniscus which is entrapped, that is one occasion. Second, if there is a ACL avulsion and only a split depression, that can also be very well tackled along with orthoscopy. Yes, there is a room for this orthoscopic assistant, but myself I have not had enough experience. Possibly orthoscopic colleague may throw some more light on this aspect of requirement.
That's nice. Probably the last question. What is the sequence of fixation in bicondylar fractures? Which one do you fix first? This is from Dr. Nitin.
Yeah. Now, in bicondylar fracture, usually you will find how it fails. So, in my sequence of fixation, I decide one factor, how this fixation is going to fail. And if you remember our failures, most of the fractures in tibial condyle fail in varus. So, I would like to prevent varus, and my varus prevention strategy is to fix the medial plate first, so that I get that interception out there is no caving in, medial plate is buttressed and it gets enough hold. And then I would go for the lateral plate. The lateral reduction, however, is kept into position prior. Hold is there. Only thing is we have to buttress it laterally. So my medial plate is usually first. However, if there is more injury on the lateral condyle, lot of depression, fragment depression, which we are correcting. So I may put lateral plate into position, hold with a rag, screws, and then complete the medial fixation and come back laterally and fill up all the others. That is my sequence of procedure.
That's nice, sir. I think there are no more questions as such currently, but they will follow in next 24 hours. So you can answer them in the forum anytime.
Yeah,
And
most welcome. Any question? And my mail ID is, they can click on that forum. I would answer them.
right.
Anybody has any specific question, I'm most ever willing to answer them. And thanks, Ashok, for this wonderful platform. What it does is, and I'm really, delighted. Always there was a time constraint in presentation.
Right.
So here, when you are giving a platform, you can speak our heart and whatever experiences you had. Thanks for that opportunity.
Thank you very much, sir. Thank you very much.
Thank you. Thank you very much. And from the whole team, they are saying bye-bye to you. The whole team is ready to say bye-bye.
Thank you. Thank you very much, everybody.
Thank you. Thank you. Thank you very much.